Our next speaker is incredible. Dr. Rolf Ewers he's a DDS, like most of the audience here. He's also an MD, a physician. He is also a PhD. And a lot of times when folks go on to get those additional credentials, they forget the knowledge from before. He remembers everything from dentistry, everything from medical school, everything from his PhD. He's gone on and become a maxillofacial surgeon. He's gone on and become a plastic and reconstructive surgeon. So he can do everything from full body down to a single tooth. And he remembers all of this. He's published numerous textbooks through Contestants Publishing. Has been chairman of the largest maxillofacial and craniofacial surgery department in all of Europe. And numerous residents of his have gone on to become chairmen of maxillofacial surgery departments throughout the world. That's the true testament of a phenomenal teacher when his students go on to become prominent researchers, clinicians, and academicians in their own right. He's hosted the International Association of Oral Maxillofacial Surgeons meeting in Vienna, Austria. He has invented and patented originally the resorbable craniofacial and maxillofacial plating system. He has invented and patented a graft material, is Algipore. He was the first surgeon in the world that actually did a tongue transplant. Took a tongue from someone who had just died, transplanted it into a cancer patient that had lost his tongue, connecting every nerve, every artery, every vein, and getting it functional. The world's first ever successful tongue transplant. He has done surgeries from head to toe and is known for large bone grafts. And here's a guy that does large surgeries, small surgeries, and everything in between. My chairman, Dr. Klein, when I was in training, he would say, big surgeon, big flaps, small surgeon, small flaps. And none of us want to be known as small surgeons, so we had big flaps and big surgeries. And that's what Dr. Evers has done in his career. Now he's going to talk about something that's less invasive, less bone grafting, less of everything. And he's not coming from a place, some folks that do small surgeries are doing small surgeries because that's all they're trained in, or that's all they feel comfortable with. Here you've got someone that does and has done the biggest surgeries, and now is saying there's a place for small surgeries, less invasive for ourselves and our patients. I think you're going to find this presentation incredibly exciting. Because the way this platform is, between my introduction and getting Dr. Evers on screen, they're going to switch platforms. So there's going to be a few seconds, few minute delay. Just hang in there. It is absolutely worth you staying here and listening to this presentation. Thank you so much.
Yeah? Yeah, I'll share the screen. Okay, so you can go ahead, Dr. Rolf. We are live now.
Yeah.
Yep.
Wonderful. So thank you. Finally, we are connected. I just heard that Aaron Garg introduced myself. So I would like to talk today about the functional bone response to short implants and TRINIA Prostheses, and if they confirm Wolff's law. The next slide, I just prepared my team until 2009. As Aaron said, I was chief in the oral surgery department, University Hospital in Vienna. And now I'm working in my private institute, CMF Institute in Vienna. It's for craniomaxillofacial surgery. I'm very happy and honored to be able to talk to you today about Wolff's law. He published this in 1892. In German, it says das Gesetz der Transformation des Knochen. It means the law about transformation of bone. It was published in 1892. And he said or postulated every change in the function of bone is following by certain definite changes in its internal conformation. And it's amazing that still this law has its ability to show what is going to happen around implants, and as I found out, especially around short implants, and I will try to explain this to you. So he said that healthy bone will be adapting to the loads under which it is placed, like implants. If loading on a particular bone increases, the bone will remodel over time to resist the new loading. And third, he said, if the loading on a bone decreases, the bone will become less dense and weaker due to the lack of stimulus required for continued remodeling. Until 2010, I performed for 36 years many different augmentation procedures. As you see, many operations. I designed the horseshoe lift for one osteotomy together with my former chief Herle in Kiel. I did all these sinus lift augmentation, vertical distractions, inlay, PSP, and only plastics, and also countless socket preservations. We actually had very, very good results, and I show you here one result being stable over 17 years. But what is so surprising on this from the beginning, then we did an iliac crest transplant, bone transplant here, stabilized it with an additional screw. And also the bone, the transplanted bone, had a massive resorption, about 80% on this side, 50% on this side, and free outside standing implants, but she cleaned it very fantastic. So it was stable for 17 years. And now I would like to have your attention to the right side of the horizontal mandible, show what it was in the beginning and how it looked 17 years later. It's not Photoshop, it's really real. So this means it always doubled, even more than it doubled on the right, and also on the left side, it almost doubled. And this certainly speaks for Wolff's law that he postulated that if the load is being changed, like here increased, certainly bone will follow the function. So like Confucius said, who wants to be happy all the time, he has to change more often. I thought we should do and try something new. And we said in 2010, how about no augmentation anymore, but using short implants, as saying maybe less will be more. In 2010, we decided with my team at the hospital that we should use a system which is already a long time in the market, like this Bicon system, which was at this time, 2010, 25 years in market. This means this year, Bicon is celebrating its 35th birthday. And the unique features of this system we will talk about now step by step. And certainly there are many, many advantages. And if Leonardo da Vinci would live in today, as he always said, simplicity is the ultimate sophistication, he certainly would use drawing this beautiful Bicon system. Certainly, I will not talk today about very easy cases like in here. You can use all kind of implants, all kind of systems. This would be not the reason for my lecture. Today, I would like to talk about implants putting in places like this. if you have a situation like this, you certainly will think, well, here should be done some kind of sinus lift with different kinds of augmentation. This lady was supposed to have an iliac crest transplantation to get later on an implant. When I started operating, I saw that she had a huge hole on the antrum to the sinus, no bone at all, and a huge perforation. So they could not have performed this bone transplant, and therefore I applied this implant without any sinus lift or something. This certainly was a compromise, and just see if this is going to work, because if you see a picture like this, you'd think, well, he's crazy. Maybe he's drunk or just stupid to do something like this. But I was lucky, and the patient was lucky. Also, the crown implant ratio is 2.5 to 1. As see, it's shown here. It is now stable more than 51 years after more than 51 months of loading. But what is so fascinating, if you take a close look into here, you see here it's bone gain. God, something happened. Why is here bone gain? And if you put it back again, you see this is no Photoshop or something. So something is happening because maybe this implant is getting moved or loaded due to the crown balance. So 2010, we started to design 3 studies with 4 by 5 millimeter ultra short locking taper short implants in the maxilla with less than 6 millimeter of bone, in the mandible 7 to 10 millimeter of bone, and then we also applied these implants after fibula transplanted bone into mandible. But today I'm not able to talk about this. It would take too long, except in one slide, and I will show you with also fantastic results. And at this time, we started to use a new material. It's a metal-free, fiber-reinforced resin material, produced, and this material is called TRINIA, and I will show you all my results fixed with these new TRINIA prostheses. Our dental technician is Paolo Perperna di Latina in Rome, and he did all the prosthetic work for us during all our study designed persons. Here you see a 59-year-old female with about 7 millimeter remnant bone. And there is no question of a standard implant. Here you would have to do some kind of augmentation, which I did for 36 years. Here we decided to apply a short implant, and just see this now after 7.3 years of loading with an excellent result. Certainly here we had a little resorption. Maybe I will talk about this a little later. Maybe it wasn't applied enough subcrestal, but we didn't have more bone to do that. Here you see the ratio of 5 to 1 between the prosthesis and the implant. So certainly this ratio 1 to 1 does not exist for this Bicon system. And I just will show a little follow-up of our longest lasting cases. Here you see it after 94 months, 59-year-old person, it's a lady. Here the ceph from the lateral side, you see the dimension of the atrophy. 59-year-old lady we just saw, 83 months, so with the ceph. This lady had a fracture, was treated with osteosynthesis, and now you see here the result. This implant was not osseointegrated, so now she's having this prosthesis loaded on 3 implants. We talk a little bit later. This is the only complication we had with a non-loading in our whole series. 55-year-old lady with a ceph, and it's stable for 74 months. And the last one I will show you, 52-year-old lady with very, very little bone in here. That's just the dorsal ventral spine, and you see stable for 60 months with excellent results as always. All our good results we published already in 1970 in December, and we are going to continue, and this you can follow up in the Journal of Oral Maxillofacial Surgery in December 17. As we saw in this one patient that the prosthesis also is stable on 3 implants, we thought maybe like here with the stool and its legs, 3 are very stable, it doesn't bend at all. So therefore we started since 2017 just to apply 3 implants in the mandible. We do this either with fixed detachable abutments or with retentive telescopic abutments, which is very elegant, or we use locator abutments or bar abutments. And if you want to have it a little bit more sophisticated, then you also may use individual milled titanium bars, and the patients do like this very much. Here I just will show you a long-lasting TRINIA on a tumor patient. As I just said, I will do it very shortly. You see here a carcinoma in the left mandible. We are doing the resection and stabilizing with titanium plates. And if the patient is free of recurrence a year later, we apply a fibular transplant, as you see in here. All our patients are fixed with intraorally with a jejunal transplant, and the first operation together with the resection and the stabilization with the titanium plate, and then later on we do this the transplantation. Here then applying of the implants a few months later, and as the bow of the mandible was not so perfectly, we had difficulty because we applied this implant too far buccally and too far lingually. Therefore, we had to stabilize the prosthesis just on 3 because we kept this implant sleeping. Here you see the TRINIA prosthesis, and now this is stable for 8.1 years, at least in September 19. So here you see the 4 implants being loaded in the beginning, then short after we put this to sleep, and now you see it 8.1 years later. And just see what's happening with this little bony dip or defect or whatever you want to call it. You see what happened due to the loading of this prosthesis, as this was not stabilized. Due to the flexibility of the TRINIA, you had some motion in between here and here, and therefore the whole mandible was able to get straightened out. You even can imagine the cortical structures which got here mineralized and got new bone. So this certainly, as the fibula just has a round bone structure of 4 to 5 millimeter, certainly it applies all according to the postulation of Wolff, which was called Wolff's law. And here you see again the magnification. This was the bone in the beginning, and 8 years later you see what happened with the bone. So this is due to function as bone postulated. And how about the maxilla? If you have a maxilla like this, very atrophic as a 60-year-old male, we applied here 4x5, and here, because it was so thin, 3x8 millimeter implants. And it's surprising also in the mandible, here you see the initial loading situation with a TRINIA bar and the prosthesis. Here you see a typical TRINIA prosthesis. In the beginning we had no pink material, but just ivory material. By now we have a pink material, as you saw later. Now we are orienting and fixing the abutments in the implants, and then later on we are able to cement this 12 or 14 piece bridge. And what is so important, the gum is free and the red wine and chocolate tastes good again. This is the CEF, and we had been very critical if this is not going to break, if this is going to stay stable, but it's now stable with a very, very good aesthetic result. And here you see it after 5.9 years, almost 6 years, 71 month loading with an excellent result, and actually no resorption around the implants. Also, they're pretty much loaded. These here we also published, also in the Journal of All Maxillofacial Surgery in beginning of 2018. So you can see all the measurements of the marginal bone level also in the maxilla. And certainly we also started in 2017 to use this system in the maxilla also with 3 implants. But this situation here is a little bit more difficult because the middle implant we have to apply in the incisor foramen and in the nasopalatal canal. And here you see a wide canal. We thought this is very good. So later on you will see it's not so positive. But here we could apply this and start doing. In the beginning, we thought a very thin one is more complicated because we have to do, and getting a result like this, we have to do some special management to apply this implant. At the beginning, we just start with our burr in the anterior part of the maxilla. Then we have to be careful with our burr and the reamer not to touch the posterior part of the canal because this is not too much bone left. And then just with the last reamer, so when we decide like a 5 millimeter thick implant, we just touch the bone back here. And then when we are doing the unloading, we may blunt in the beginning and later on blunt a little bit more. So then we will be able to apply our abutment. And here you see a case which the teeth you couldn't preserve. And that's the situation where the teeth are outside the maxilla. 3 months after extraction, we started then again a DVD, a cone beam, and see the result, and then applying the implant in the middle into the nasopalatal canal, and you see the result. And just see how much the bone changed from here to this situation 3 months before. So it's certainly quite a change, and it's possible to apply an implant into the foramen and into the nasopalatal canal. Then 6 months after implant placement, uncovering, you see partially covered with bone, and then the prosthetic workup, impression taking, and then this is the final prosthesis. Here you see now pink TRINIA material and the 3 sleeves for screw retention. As I said in the beginning, we thought it's good to have a large foramen. It's not so positive, and these are beginners' problem. We didn't apply 2 thick implants and these huge foramen, so 2 of them we lost. We could replace them with thicker implants, and now they are successful also. So we come to our overall statistics with up to 9 years of recall. In the mandible, we had treated until now 33 patients with 3 or 4, 5 millimeter thick, short implants. This is altogether 119 implants. 2 implants did not osseointegrate, and 1 implant is not loaded to nerve disturbances. I will show you a few seconds. And 1 not osseointegrated implant I have shown it to you already. In the maxilla, we have treated 38 patients with 3 or 4, 5 millimeter implants. This makes 135 implants, and 2 implants are also not as integrated, and 2 implants we have lost. This is up to November 2019. So let me talk a little short about the special features of this system. It's the 1.5 degrees locking taper, the sloping shoulder, and the plateau designs. These are the 3 most specific features. And due to the double platform switching, together with a Morse taper connection, we do have a bacterial seal. And as we have a spherical abutment form, we call this the double platform switching. And this double platform switching is something which very often gets to bone gain, as you see in this picture from here to here. And about this patient I will talk a little later. It's after 15 months already. And this is the patient you know already with the tumor reconstruction with a fibula transplant. So we call this the double platform switching. We call this a bone production chamber. And this bone production chamber you find also in the plateau design, which exists already more than 50 years in other implant systems. And these chambers are 30-60 degrees around the implant. And this certainly are also 360 degrees bone growing chambers. The logic of Bicon with the fins and plateaus are different healing and highly osseoinductive surfaces, better bone quality, more surface area, and better distribution of stress, as you see in this publication by Mufti between these systems. And here you certainly see that Bicon has the largest surface of these 5 different implants. A big paradigm change in the Bicon implant system is that we do not have the so-called pressure principle due to tapping in the implant into the bone, where we have slow growing positional bone. We do have with this implant system a so-called callus principle, because the hole is actually larger than the implant. We just have a press fit system, and therefore we have an intramembranous, fast growing bone with Haversian-like structures, as I will show you. So the pressure leads to osteoclastic activity. The bone gets resorbed, and then just later on, you get a positional bone. And this bone is certainly not as high quality bone as if you have no pressure, you just have osteoblastic activity. And this leads then to lamellar bone, as Mufti showed already in many, many histological workup. And he's always saying this system, these healing chambers, are leading to unique long-term lamellar bone with Haversian-like bone morphology, which you see here with the lamellar bone, the Haversian canal with the nerves and the vessels. And this he has published very, very often in many, many publications with many, many histology workups. As you also see here, the beautiful histology, and the arrows here are depicting the bone remodeling. This is 12 months later, and this also is after 8 years after placement. Here again, all these fibrous structures around these implant histology. Let me talk a little bit about loading. If you have a long implant, a standard long implant like 14 millimeters long, and you have a vertical displacement, then you see the reaction in the finite analysis around the whole implant. The same after, like here, 5.7 millimeter short Bicon implant. You see here all the loads, and here the more red you have, the more load you have. But what happens if you are horizontal displacement? You recognize in a standard long implant, the activity is just shown in the upper third. The lower 2/3 are non-active at all in the horizontal displacement. In comparison to a short implant, it's all around the complete length of the implant. If you take this now from the right side and the same from the left side and go back and forth as we have this with normal occlusion and mastication, then you will understand why Mufti is publishing this graph that he says with angled occlusal forces from one and the other side, we have something like this little implant is turning around in the bone because the bone is viscous, and this seems to be possible. And therefore, we explain why we have bone gain around the abutment connection, and also bone gain, as I showed you, even in the floor of the sinus. This movement of a little implant in the bone leads us to the Utah paradigm of skeletal physiology published by Frost in 1960, who called this a mechanostat of modeling and remodeling threshold. And these thresholds are measured in strains. And he could show if we have too little distribution of load to the bone, you will have bone loss. Then you have an adaptive state. And if you have a good overload, a positive overload, you will sometimes have bone gain. He published this actually in fracture treatment, but this also fits perfect for short implants. And this means Bicon designing this implant was very lucky enough to have this implant somewhere in between the adaptive state and in the bone gain state. And therefore, we can show these good results on our patients. So this means if you have 10 years after loading this bone around an implant, something must happen to this implant because due to the occlusion, this crown is getting loaded, and due to the load, you have some kind of motion or whatever you want to call this, and you will have bone grain around the neck of this abutment to find these beautiful mineralized cortical structures and these fibers which are getting mineralized. The same finding you also see in the maxilla after doing a trestle sinus lift with some augmentation material like Synthegraft in this case, and you see then already 3 years later, beautiful response of the bone to this loading of this implant. So the bone remodeling is always seen, and you can even measure this. Here you see the augmentation material, and already more than a year already, or the next year, you will see this already here being happen. After 8 years of loading, you see tremendous mineralization of all the trabecular structures of this bone with an excellent result. And I'm convinced that there is no discussion that this just happens due to function, due to positive, not overstressed load. If you see a case of this I operated in 1914 with these horrible non-preservable teeth. Then you see here the application of the implants. 16, you see the change here, the crestal sinus lift with sinus abutment. Here you see the mineralization of this augmentation material, and here 33-month loading. And it's a very interesting patient because this 56-year-old female patient is taking Prolia for several years and still this been able, all these implants to apply and being stable. Also, the patient is taking denosumab Prolia medication. So again, the 1-to-1 crown implant ratio certainly does not apply, and you see this after 8 years here in the maxilla and this in the mandible. So it's a huge difference. And here, like Urdaneta published this and could measure this, and it's published in the International Journal of All Maxillary Implants in July 10. And always we find this, and therefore we say if the nature, like with the redwood tree, with a huge difference of 3 to 100 meters between the roots and the tree, you see this is a mechanical law in the Burj Al Khalifa in Dubai, 830 meter to 50 meter, and it's stable. So why should this not be stable in the human body? Certainly, it's a paradigm change with implants that Bicon says at least you should apply the implant subcrestal at least 2 millimeter. You see here a case where I did not apply this deep enough, so it's not so happy. It doesn't do any harm, but the results, long-term results, are much better, as you always will see, even also on my slides. And very interesting, you always also have to think about if you're using full thickness flaps, that you always will have some kind of resorption after the operation. This is a good example. You see where I applied these 3 implants, and you see the sinus lift is just, the implant is put about 2 millimeters subcrestal, and the sinus lift is just at the level of the bone. November 7, 18. June 24, 19, just see that just because of the operation, we have lost some kind of bone, and the abutment is outside already because the bone resorbed just by itself. The implant insertion is just very positive and perfect, but the bone, just because of losing its periosteal coverage and then being sutured again, you have some kind of resorption. And the same you see here, May 11, September. See how much bone we had in the beginning, and you see now the bone level here. So you always have to take into account that you always have some kind of bone, crestal bone resorption, just because of removing the periosteum from the bone if you're preparing a full thickness flap. Therefore, I always prefer to prepare a supraperiosteal preparation flap, the so-called split thickness flap, so I leave the periosteum on the bone, and this certainly is much better. It's a little bit more difficult to operate, but the crestal resorption after the operation will be less. So let's talk about the 360-degree positioning. It's an extraoral cementation that enables an extraoral cementation. It makes possible the integrated abutment crown, the IIC. It's possibility of slight aesthetic adjustments. I will show in a little seconds. Prosthetic orientation and seating of the abutment, very easy to do, and retrievability, versatility, and tractability due to this system. And this, as I said already, the hemispherical bone is bone gain. The larger the hemispherical bone, the better, as I will show you in these cases. Here you see the beginning, And here, after several years, so it's certainly much better. And even here, a difference that you see here, it's less hemispherical base, less bone, longer hemispherical base, more bone. So it's very often to see 1998, 2011, you see what's happened with a large hemispherical base. Here again, very dramatic to see a bone gain in between 14 years from this situation to this situation. There you're not able to talk about any tricks and anything. This is just functional load and response of the bone to this functional load. The same bone gain here, November 2000, 17 years later. What a beautiful bone around these abutments. Bone gain again, situation like this. You see here still no bone, now 4 years later, perfect bone. And even in cone beam, you see, due to the better distribution of compressive forces, you see the reaction of the bone to it. So crestal bone gain is mostly seen in single loaded implants, certainly. Seldom seen in splinted implants, as I showed you in one case with a fibular transplant, because the span was long and in between one implant kept been sleeping. And here I just want to show you a case. I showed you one X-ray already. You will recognize this. This is a 53-year-old patient. He came with an infected long standard implant, no sinus lift whatsoever, but coming out pus. So I waited more than 1 year, and he regenerated beautiful the bone, but he had a chronic sinusitis. I applied the implant. As it was now not bone enough, I did not apply it too crestally enough, but I did not perform a sinus lift in addition. But I could take the bone and I remove from here and make a histology, and you see a beautiful recovered bone. So I was sure that this is going to be a positive result. Initial loading, and now you see where the bone was here. These two pictures you saw already. After 15 months loading, you see some kind of bone gain, and I was very happy to see this and said, oh, God, they are right. Here you have bone gain. So this is 15-month loading. Then it was 30-month loading, and I still was fascinating that we have some bone gain. And if you have taken a close look, you see here is something happening. And certainly I did not react immediately, but after a few months, I finally recognized this because the patient had a fistula. So I had to remove these tools, and I was horrified because it was a lot of infection, and I was afraid that I'm going to lose this implant. Actually, it was no question. After 33-month loading of this implant, probably I'm going to lose it. The patient was lucky, I was lucky. After 37 months loading, this implant stayed stable. Here again, all the bone, even inside the crest, and here applying the implant. And now you have here 50-month loading, and now you have here this situation. The second implant is 42 months loaded, and the first implant is now loaded 7.8 years. Also, it was an infectious site, and it was very, very critical. And you see even again here after 15 months, it was bone gain, and it came almost back to the same situation again. And you have a lot of bone inside the bottom of the sinus. So due to the loading of this situation stayed stable, and you had a lot of bone gain in this situation with this excellent intraoral aesthetic prosthetic result. Let me talk a little about sloping shoulder. If you have a standard implant like this and you want to apply this very close, like in the anterior front, it is very positive that you have this sloping shoulder because bone is able to grow in between. And you have a situation like this, and the sloping shoulder, you all will have a bony papilla in here and lots of bone in between. If we're talking about the screw connection, we will see always a bacterial film in comparison to the screwless connection due to the Morse taper. This certainly
The locking taper is an ageless way of attaching components together. It is a firmer connection than a screw connection. Locking tapers are widely used in industry for many applications, such as orthopedic hip implants, chucks on dental lathes, automotive components, and propellers on ships. Ken Keating from the Dublin Institute of Technology in Dublin, Ireland, concluded that the forces, fit, material properties, and service conditions all work against screw-retained abutments, but these same factors work for the locking taper abutments.
So he could say it in few words much better than I could have said this. So this is the conical connection. It's a bacterial seal. And if ever you have to remove it, it's very rarely that you have to remove the ISC crown, then you will see sometimes slight pedicel bleeding. Even in a thin biotype, you see this. And you actually do not have to remove this. You don't have to unscrew this. You just don't have to remove this. If you have, and therefore you have these beautiful soft tissue situations. Another paradigm change in healing bone is that we actually do not use any irrigation, also not very much in using the pilot drill. But certainly we are never using this with the latch reamer and the hand reamer. There we do not have any irrigation, and we are just drilling with 50 RPMs. As we do not have any irrigation, we are able to collect bone, and this bone is being collected and later on applied over the implant. As you just see here, in the follow-up with so much collected bone, just fitting it over the implant, and then having half a year later so much bone recovery that we have to remove a bone with a round burr just to uncover the implant. The healing time always is 4 to 6 months in the maxilla and 2 to 3 months in the mandible. And here again, with the sloping shoulder, it supports the papilla. And this you can see very good in adolescent cases, like here, a 15-year-old male patient. Many will say, no, you shouldn't use this because the bone grows, the skull grows, and the implant will be in a wrong position. I just will show you a case from Dr. Morgan. And you see the application, and you see this then after the prosthetic workup. And this is 206. After 7 years, as expected, the tooth is too short. With the Bicon system, it's very easy because it's acrylic. You just do this bed chair side and prove this, and then it's now after almost 10 years loading, perfect fit. And just see, due to the sloping shoulder, how much bone you have here in below the papilla. This is now 06, 10 years later with this situation. And see how close implant has been able to be applied to the neighboring teeth. And everybody will say, and what happens with these teeth? They will be damaged. I did these experiments 1976 to 78 and published this 1980, that we applied a lot of screws in beagle dogs just to lacerate the roots. You see here many screws into the roots and around the roots, and you see what happened here. We lacerated this histology with the screw. We lacerated the tip of the screw, and just see of the tooth, and just see in polychromatic hard sectioning what happened. Although this was certainly injured and damaged, the periodontum recovered completely because we injected Indian ink into the vessels before we sacrificed the animal. You see everything what is black, this is vascularized. And so the periodontum completely and the root completely healed and recovered with a normal periodontum. Another laceration in here, you see how it was lacerated. The cementum, the dentin, and the pulp was injured completely. And you see even the pulp regenerated, as you see the Indian ink is here, and here the periodontum and everything regenerated. So certainly if you lacerate very little living tooth with an implant, you certainly will be expecting that this is recovering completely. So let me just talk about major advantages of the delicately soft tissue handling and ultra short implants. And this certainly is the minimal sinus lift. Professor Marincolo worked a lot about, and he just systematized this. And here you see typical with a hand reamer lacerating the cortical bone in the sinus. And you have to know that the latch reamer is round and has no sharp tip. And the hand reamer has a sharp tip in here. And with this sharp tip, you can lacerate the cortical structure of the floor of the sinus. And after you did this, then you're able to apply your material, and then you're able to lift with your special instruments. With the augmentation material, you are able to lift without laceration the mucosa, and then you are able to apply these two implants subcrestally. And if having neighboring teeth, you are able to use the sinus lift abutment, which is very elegant. So here you see a typical case in the X-ray, lifting it. And this is 7 years follow-up with an excellent result. So you will ask yourself, did I make mistakes? Maybe my biggest mistakes, after a while, I thought Bicon implants do not need bone. So I have a learning curve. In the beginning, everything worked, and I was exaggerating a little bit and using it in a situation with too little bone. So I had some complications. So I know now little bone, even the Bicon implant is needing. And I do have to apply it enough subcrestally, as I told you already. This case, you know, and certainly you can say, I could have put this more subcrestally, but I was afraid of perforating. By now, I rather would go deeper, because here you see from this, you have here little bone resorption. And the deeper you have the implant, the better results you will have. So what did I learn the last 10 years using Bicon implants? Subcrestal, deep, deeper, deepest, at least 2 millimeters, better 3 millimeters. It's always the result. You see it in this case again, and you see the result is good. But here you certainly have better bone situation than around here. So if you should get after 10, maybe 20 years, some problems, the problems would be rather here than here. So remember, deep as possible. This is now 57 months loading. Fortunately, no problem at all, but it could be. So what did I learn? Maxilla, as often hand reamer, using hand reamer because the bone in the maxilla is so soft, it's always better to use it a hand reamer in the maxilla than a machined hand reamer. If you're very close to a mandibular canal, you should use the latch reamer, and you should turn as slow as possible, very, very slow. Then you're able to get a result like this. You're able to cut up all the way to the structure of the nerve. If you do it very slow and very gentle, you even notice that this now is going to be in the canal, and you have a beautiful result like this. So complication rescue, cases where only ultra short implants will accomplish the desired outcome, is like a situation like this. So Stephen Millman in Texas was brave enough not to remove this broken Straumann basket implant, but he just put an implant over this. Actually a little bit crazy, but he was successful and the patient happy. 4 months in function with bone gain. Even here you see bone gain, and this is 3 years after loading. Just an excellent result, and it's a perfect rescue situation. You know, very often you hear about the very long zygomatic arch implants, and it's a huge operation, very risky operation. And Tom de Witt van Leeuwen in Belgium just had this case coming into his office with this complication, and he solved this with a sinus lift and 4 short implants. He allowed us to show this to you with an excellent result. This is a very bad result. If you have a situation like this, we just ask, why is this necessary? So you see, I learned quite a bit in the last 46 years. And the first 36 years, I treated my patient like this patient you know already, and it was positive after 17 years. This patient you know also. This was a local anesthesia operation, about an hour operation compared to this, to general anesthesia, long-lasting pain in the hip and everything. So I think this is so much more elegant to use a short implant as we did. And certainly, if we're talking about resorption, and you saw the resorption here, and I showed you the resorption, if we talk about resorption, then I have to tell, especially the young person, you just have to wait. Resorption is just a question of time. This patient came to me, was treated standard with an only transplant. I applied some resorbable augmentation material produced out of algae. I was lucky to use this. You see here it's turned a little bit into bone. I applied 2 Xyph implants, and just see what happened 14 years later. This bone transplant, which was well taken, has resorbed completely. The implants are located just in the algae pore bone. The algae-derived augmentation material I applied in here, and a little bit the original bone. So you just have to wait and see what happens with resorption. And that cases like this, with so much bone, was treated in my hospital with a distraction device. I'm still upset that we did things like this, because this surely is unnecessary. Just short to minimize, plateau design is important, screwless connection with bacterial seal, double platform switch in at least 1 millimeter subcrestal implant position. The last few minutes I would like to talk to you about TRINIA. It's a revolution of metal-free cut-cum material, 40% resin, 60% fiberglass, either in ivory or in pink, and in 3 different sizes. The same material, TRINIA, is being applied in the wings of the Boeing 787 Dreamliner, and it has a 69-degree upward flexibility, which is really beautiful visualized in here. So TRINIA has flexural strength. Its ability of a material withstands bending forces compared to non-modulus of elasticity like titanium. Therefore, we may have a cantilever or a so-called cantilever of 15 millimeter and longer, like here an extension, we call it extension, I will explain in a second, 25 millimeter. And certainly Friedrich Hebbel, a German poet, once said it often takes more courage to change one's own opinion than to remain faithful to it. So we changed our opinion and used this since 2010, this material, it's been built. And it's so fascinating because we are talking about class 1 lever. If we're having a bridge and this part is the cantilever, if we have the torque in here and we have force in here, then certainly we have a lifting up here. If we're using a flexible material like TRINIA, we do not have a lever, and certainly like in the Coke bottle as simulated here, certainly we are not talking about a cantilever anymore, but about an extension. And this is the big difference. And here you see it, if you have a lifting situation, very often, if we have a case I operated more than 25 years ago, and the patient then came in and had problems in here and not outside here because of this system, because the cantilever is just lifting up the two implants and you always have the problems in the middle. So this certainly is a paradigm change, and therefore, since TRINIA is not a rigid material, it cannot be a lever or cantilever by definition, and therefore we say the longer the extension, the better. And this certainly is shown in this case. Due to the not perfect positioned implants, which I did myself, I applied these implants too far labially. Paolo, my technician, asked me if I was drunken applying these implants so much labially, and he solved my problems in applying the screw abutments in front of the teeth. But the result was a huge extension, and we had been afraid that this is certainly going to fracture and will not be stable, because at this time we called it a cantilever and did not know at this time that the longer the extension, the better. And here you see already this case, and now you see how much longer the stability was lasting. 94 months, 7.8 years. This is stable because this is flexible and the TRINIA material is so excellent. So the screw retained prosthesis has these parts and it works just perfect. But certainly I have to report about about complication. Our studies are now in the 10th year. We have 143 TRINIA crowns, 59 TRINIA bridges, and 121 TRINIA full arch prostheses. The problems are not very high. 1 chipping, 2 hairline cracks, and 2 fractures of December 19. This is the chipping. This patient you know already. Here it's a little chipped, chairside, repair, no problem. This was a chipping in a lady. She had a very often seizures because she was an epileptic. The father said, apply as many as possible because she falls so often on her face. So this we did not have to repair because she had enough implants. We just applied new teeth, and unfortunately she died short after this. And a new seizure falling on her face. Here we have 2 little infractures. The material still stays stable. And as we show you here, we have this fracture because this part was not thick enough. This was our 7th case after 50 months, 2 months of loading. And this is, again, you see it's not long enough, strong enough. And here again, it's overload. Material is just getting tired because after 24 months, these are the only 2 fractures we have, and this picture shows this, at least we have to have 2 millimeters of TRINIA material over the abutment, and here it would be not enough. So it modifies easily with a finishing burr. It bonds readily and well to all the materials, and it's 70% lighter of zirconia, and it certainly does not fracture, as you see in here. So many advantages, and it's 70% lighter than zirconia. So TRINIA certainly is forgiving my mistakes. Our results would not be possible without this unique material. And certainly you may follow all our cases because we publish this all in the Bicon webpage, www.bicon.com. We have over 300 full cases studies, over 1,700 clinical images, radiographs, case dating back decades, hours of instructional and case studies. So you really can learn by this fantastic webpage. And I learned a lot too, because Boston is far away from Vienna, and in Austria it has not been used at this time so much when I started learning. So the literature is found in here. Over 300 clinical cases are found in here, and it's perfect published. In addition to this, you certainly may use the 2017 published book, The Bicon Short Implant, edited by Dr. Morgan, and many cases are here, and the whole history and all the basics are also being put in here. And certainly if you're interested, we are performing, not now because of the virus crisis, but we are performing operating procedures, and we, if wished, we are also doing cadaver courses. Cadavers are operated, fresh cadavers, and I operated under the microscope, so everybody sees the procedure perfect, and two persons are splitting one head for all the practical courses. So I hope I could have shown you, does Wolff's law explain a little bit why the short implants work so well, and we are able to treat so many needed patients with this, so that I'm able to say by now less is more. And also with TRINIA, we are able to treat so much more patients than we used to treat. And with this, I would like to thank you for your attention. And if you are interested and have many questions, please contact about lab technical problems and procedures with p.pertolini.bicon.com, or with when you have a question to me, Rolf, my first name, at cmf-vienna.com. Thank you very much.